Every 6 seconds, somewhere in the world, someone is having a stroke. And here's what might genuinely surprise you about that statistic. The majority of people experiencing a stroke right now, in this very moment, don't actually realize what's happening to them. They feel a sudden weakness in their arm and think they slept on it wrong. They notice their speech slurring and assume they're just tired. They develop a severe headache and decide to lie down and wait for it to pass. But what's actually happening inside their brain during those critical minutes is one of the most time-sensitive medical emergencies in all of human physiology. Because unlike a heart attack, where the heart muscle is being damaged, a stroke is actively destroying the organ that controls everything else. Your movement, your speech, your memory, your personality, your ability to recognize the faces of people you love. And the window to stop that destruction is shockingly small. So today, we're going to walk through exactly what happens inside your brain when a stroke occurs. Not in vague terms, but step by step, minute by minute, at the cellular and vascular level. We'll discuss the two main types of strokes and why they require completely opposite treatments, what's happening to your neurons during the critical first minutes, why time matters more than almost any other factor, and most importantly, the warning signs that could save your life or the life of someone you care about. Because the research is very clear on this, the difference between full recovery and permanent disability often comes down to whether someone recognizes what's happening within the first 60 to 90 minutes. Now, before we discuss what goes wrong during a stroke, we need to understand what's supposed to happen in a healthy brain. Your brain represents only about 2% of your total body weight, but it consumes approximately 20% of your body's oxygen and 25% of its glucose at any given moment. That is a staggering metabolic demand for such a relatively small organ. And the reason for that demand is simple. Your brain contains roughly 86 billion neurons, and those neurons are firing constantly, managing everything from your heartbeat to your conscious thoughts. To support that level of activity, your brain requires a continuous, uninterrupted supply of oxygenated blood. That blood is delivered through a network of arteries, the two carotid arteries running up the front of your neck, and the two vertebral arteries running up the back. These four major vessels branch into progressively smaller arteries as they move deeper into brain tissue, eventually becoming tiny capillaries that deliver oxygen and glucose directly to individual neurons. Now, here's what makes the brain uniquely vulnerable. Unlike muscle tissue, which can survive for extended periods without oxygen, or liver tissue, which has significant regenerative capacity, neurons have almost no tolerance for oxygen deprivation. When a neuron is deprived of oxygen for more than 3 to 5 minutes, it begins to die. And once a neuron dies, it does not regenerate. You do not grow new neurons in most areas of the adult brain to replace the ones that are lost. That tissue is gone permanently. So let's talk about what happens when that blood supply is interrupted. And there are two main ways this can occur. The first, and by far the most common, accounting for approximately 87% of all strokes, is called an ischemic stroke. Ischemic means caused by a blockage. Somewhere in the network of arteries supplying your brain, a clot forms or a piece of plaque breaks loose from an artery wall and gets lodged in a smaller vessel downstream, completely blocking blood flow to the tissue beyond that point. The moment that blockage occurs, a very specific sequence of events begins in the affected brain tissue. Within seconds, the neurons downstream from the blockage stop receiving oxygen and glucose. Their energy production, which depends on a process called oxidative phosphorylation happening inside the mitochondria, shuts down almost immediately. Without energy, the sodium-potassium pumps embedded in the neuron cell membrane, which normally maintain the electrical charge that allows neurons to fire, stop working. Sodium floods into the cell, the neuron swells. And because neurons are packed incredibly tightly together in the brain, that swelling starts to compress surrounding tissue and blood vessels, which further reduces blood flow to nearby areas. This creates what researchers call the ischemic penumbra, a zone of tissue surrounding the core blockage that isn't getting enough blood to function normally, but isn't quite dead yet either. That penumbra is critical because it represents salvageable brain tissue if blood flow can be restored quickly enough. But here's where time becomes absolutely essential. Research from the National Institute of Neurological Disorders and Stroke has shown that during an ischemic stroke, the brain loses approximately 1.9 million neurons every minute that passes without treatment. Every single minute. To put that in perspective, that's roughly 32,000 neurons per second. The ischemic core, the area directly affected by the blockage, is often unsalvageable. Those neurons are dying within minutes. But the penumbra, that surrounding zone, can survive for 60 to 90 minutes, sometimes longer, if circulation is restored. And this is why stroke neurologists have a saying that has become almost a mantra in emergency medicine. Time is brain. Every minute you wait to seek treatment is brain tissue you will never get back. Now, the second type of stroke, which accounts for about 13% of all strokes but tends to be significantly more deadly, is called a hemorrhagic stroke. Hemorrhagic means caused by bleeding. In this case, a blood vessel inside the brain ruptures, and blood spills directly into the surrounding brain tissue. This can happen for several reasons. Chronic high blood pressure weakens artery walls over time, making them more prone to rupture. An aneurysm, which is essentially a weak, bulging section of an artery wall, can burst. Or in rarer cases, abnormal tangles of blood vessels called arteriovenous malformations can rupture. Regardless of the cause, blood that's supposed to stay inside your arteries is now flooding into the brain tissue itself. And this creates two simultaneous problems. First, just like in an ischemic stroke, the tissue that was supposed to receive blood from that ruptured vessel is now being deprived of oxygen. But second, and this is what makes hemorrhagic strokes so dangerous, the blood that's leaking out is toxic to neurons. Blood contains iron and other substances that, when they come into direct contact with brain tissue, trigger a massive inflammatory response. That inflammation causes even more swelling. And because the brain is enclosed in a rigid skull, swelling has nowhere to go. Intracranial pressure, the pressure inside your skull, starts to rise. And as that pressure increases, it compresses the brain against the inside of the skull, which can damage tissue even in areas far away from the original bleed. In severe cases, that pressure can become so extreme that it forces parts of the brain downward through the opening at the base of the skull where the spinal cord exits. This is called brain herniation, and it is almost always fatal. A landmark study published in the journal Stroke followed over 2,400 patients with hemorrhagic strokes and found that mortality within the first 30 days was approximately 40 to 50% compared to 10 to 15% for ischemic strokes. And among survivors, roughly 60% experienced significant long-term disability. The difference in outcomes comes down to one critical factor. You cannot treat a hemorrhagic stroke the same way you treat an ischemic stroke. And this brings us to one of the most important things you need to understand about strokes. The treatments for ischemic and hemorrhagic strokes are not just different, they are opposite. And giving the wrong treatment can be catastrophic. For an ischemic stroke, the goal is to dissolve or remove the clot that's blocking the artery. The most common treatment is a medication called tissue plasminogen activator, or TPA, which is a powerful clot-busting drug. When administered within the first 3 to 4.5 hours after symptom onset, TPA can dissolve the clot, restore blood flow, and dramatically reduce the extent of brain damage. Studies have shown that patients who receive TPA within that critical window have a 30% higher chance of full or near full recovery compared to those who don't receive it. But here's the problem. If you give TPA to someone who's having a hemorrhagic stroke, someone whose brain is already bleeding, you will make the bleeding worse, significantly worse, because TPA prevents blood from clotting. That's its entire function. So the first thing that has to happen when someone arrives at the emergency department with stroke symptoms is imaging, a CT scan or an MRI to determine whether the stroke is ischemic or hemorrhagic. For hemorrhagic strokes, the treatment is often surgical. Neurosurgeons may need to repair the ruptured vessel, remove the accumulated blood, or in some cases, relieve the pressure inside the skull by temporarily removing a section of bone. The procedures are complex, high risk, and time sensitive. And this is exactly why recognizing stroke symptoms early and getting to a hospital immediately is so critical. Because whether the stroke is ischemic or hemorrhagic, the window to intervene effectively is measured in minutes, not hours. The longer you wait, the more brain tissue is lost, and the lower your chances of meaningful recovery become. So let's talk about the warning signs, because this is information that could genuinely save a life. And I want you to think of someone specific while I'm explaining this. A parent, a spouse, a close friend. Because statistically, someone you know will experience a stroke at some point. The question is whether you'll recognize what's happening in time to get them help. The medical community has developed an acronym to help people remember the most common stroke symptoms. It's called FAST, F-A-S-T. F stands for face. Ask the person to smile. Does one side of their face droop or feel numb? A stands for arms. Ask them to raise both arms. Does one arm drift downward or feel weak? Is their speech slurred or strange? And T stands for time. If you observe any of these signs, time to call emergency services immediately. But there are other symptoms that don't fit neatly into that acronym, and they're just as important to recognize. Sudden, severe headache with no known cause, particularly if it feels like the worst headache of your life, can indicate a hemorrhagic stroke. Sudden trouble seeing in one or both eyes, sudden trouble walking, dizziness or loss of balance and coordination, sudden confusion or trouble understanding speech. Now, importantly, these symptoms typically come on suddenly, not gradually, over hours or days, but within seconds to minutes. That sudden onset is the key distinguishing feature. And many people, when they're experiencing these symptoms, will try to convince themselves that it's nothing serious. They'll sit down and wait for it to pass, they'll take some aspirin and go to bed, and every minute they wait is brain tissue they're losing. I had a patient, Robert, 68 years old, who woke up one morning and noticed his left hand felt clumsy while he was making coffee. He dropped his coffee mug, which shattered on the floor. His wife asked if he was okay, and when he tried to respond, his words came out garbled. He immediately called emergency services. By the time the ambulance arrived, about 8 minutes later, Robert's symptoms had actually improved slightly. He could speak more clearly. His hand coordination was better. And he told the paramedics he didn't think he needed to go to the hospital. But his wife insisted, and thank God she did. Because the CT scan showed an ischemic stroke in progress, he received TPA within 90 minutes of symptom onset. And today, 3 years later, Robert has no residual deficits. He recovered fully. But if his wife had listened to him that morning, if she had let him go back to bed and wait it out, the outcome would have been drastically different. Now, let's talk about risk factors, because while strokes can happen to anyone at any age, certain conditions and behaviors significantly increase your likelihood of having one. And many of these risk factors are modifiable, meaning you can actually do something about them. The single biggest risk factor for stroke is high blood pressure, also called hypertension. Chronic high blood pressure damages the inner lining of your arteries, making them more prone to developing the plaques and clots that cause ischemic strokes. It also weakens artery walls, making hemorrhagic strokes more likely. Research from the American Heart Association has found that controlling high blood pressure can reduce stroke risk by up to 48%. The second major risk factor is atrial fibrillation, an irregular heart rhythm that affects millions of adults, particularly those over the age of 65. When your heart beats irregularly, blood can pool in the heart's chambers and form clots. Those clots can then break loose, travel through the bloodstream, and lodge in the brain, causing a stroke. PI, People with untreated atrial fibrillation are 5 times more likely to have a stroke than people with normal heart rhythms. Other significant risk factors include diabetes, which damages blood vessels over time, high cholesterol, which contributes to plaque buildup in arteries, smoking, which doubles your stroke risk, obesity, physical inactivity, and excessive alcohol consumption. And there's a genetic component as well. If you have a close family member who has had a stroke, your own risk is elevated. But here's the encouraging part. A study published in the journal Lancet Neurology analyzed data from over 32,000 stroke patients across 32 countries and found that approximately 90% of strokes are associated with modifiable risk factors. 90%. That means the vast majority of strokes are potentially preventable through lifestyle changes and medical management. Know your blood pressure. If it's elevated, work with your doctor to bring it down through medication, diet, exercise, or a combination of approaches. If you have atrial fibrillation, talk to your doctor about anticoagulation therapy. Manage your diabetes if you have it. Keep your cholesterol in check. Stop smoking. Stay physically active. Limit alcohol. These aren't abstract recommendations. These are evidence-based interventions that directly reduce your stroke risk. Now, I want to address something that often gets overlooked in discussions about stroke, and that's recovery. Because while it's absolutely true that stroke can cause devastating, permanent damage, it's also true that the brain has a remarkable capacity for adaptation and healing, particularly when rehabilitation begins early and is pursued consistently. This capacity is called neuroplasticity. It's the brain's ability to reorganize itself by forming new neural connections. When a stroke damages a particular area of the brain, say the region that controls movement in your right hand, other areas of the brain can sometimes be trained to take over that function. It's not a perfect process, and it doesn't work for everyone. But the research on stroke rehabilitation and neuroplasticity is genuinely encouraging. A study from the American Stroke Association followed stroke survivors who participated in intensive physical and occupational therapy, starting within the first few weeks after their stroke. Those who engaged in consistent, targeted rehabilitation showed significantly better functional outcomes at 6 months and 1 year compared to those who delayed or avoided rehabilitation. The neurons that died during the stroke cannot be brought back, but the surviving neurons can be retrained. And timing matters here too. The first 3 to 6 months after a stroke are often called the critical window for neuroplasticity, when the brain is most responsive to rehabilitation efforts. But even beyond that window, continued therapy can produce measurable improvements. I've seen patients regain lost function years after their stroke through persistent, disciplined rehabilitation. The key is consistency. Physical therapy to rebuild strength and coordination. Occupational therapy to relearn daily tasks. Speech therapy if language or swallowing were affected. These aren't optional. They are essential components of recovery. And the patients who approach rehabilitation with the same seriousness they would approach any other life-saving medical treatment are the ones who tend to recover the most function. So bringing this full circle, a stroke is not a passive event that simply happens to you, with no warning and no opportunity for intervention. It is a medical emergency with recognizable warning signs, identifiable risk factors, and a treatment window that, while narrow, is absolutely real. The difference between devastating permanent disability and meaningful recovery often comes down to 3 things. First, recognizing the symptoms when they occur. Face drooping, arm weakness, speech difficulty, sudden severe headache, vision changes, loss of balance. These are not symptoms you wait out. These are symptoms that require immediate emergency care. Second, getting to a hospital as quickly as possible. Every minute counts. The phrase "time is brain" is not an exaggeration. It is a physiological reality. The faster you act, the more brain tissue can be saved. And now I want to hear from you. Drop a comment below and tell me, have you or someone you know experienced a stroke? What was that experience like? What do you wish you had known beforehand? I read every single comment on this channel, and your stories help other people understand why this information matters. Thank you so much for watching. It means everything to everyone here. And with that said, we'll see you in the next video.